Question number 3 from the 2024 Italian Medical Specialty Entrance Exam test. That was a mouthful. We got shuffled answers compared to the actual exam for, study purposes, of course. Pause the video before I answer, and then I'll explain step by step. Let's go. A 75-year-old woman with a known history of multiple gallstones comes to the ER in severe shock. She has hypovolemia, tachycardia, sweating, fever, jaundice. This is all after an episode of a colic that started 3 days earlier and was treated at home with antispasmodics. What is the most likely diagnosis among the following? A. Intestinal perforation. So, intestinal perforation can cause shock. Also, it can cause severe acute symptoms as a consequence of that. But the clinical picture with gallstones, with fever, with tachycardia and jaundice is, more suggestive of a biliary pancreatic complication rather than an intestinal perforation. So A is not right. Answer B, liver tumor. A liver tumor may cause symptoms like abdominal pain and jaundice. That's true. But the acute presentation with shock and the fever, all after a biliary colic episode, it's not typical of a liver tumor, something that grows over time and, it's more of a chronic nature. This is just too acute of a clinical picture. The symptoms are more consistent with, I would say, acute pancreatitis. So let's go to the next one. Speaking of the devil, acute pancreatitis, answer C. So this, I would say, is the most likely diagnosis. Acute pancreatitis could be a complication of gallstones occurring when the stones migrate and, just block the pancreatic duct. That's a classic one. So symptoms include abdominal pain, fever, tachycardia, and, in severe cases, shock. Answer D. Chronic hepatitis typically does not represent with such an acute and dramatic picture as described, right? So as we said with answer B, answer D is just not it. Additionally, chronic hepatitis rarely manifests with shock symptoms, and by then it's not chronic anymore. That, is a segue to our next answer, acute hepatitis, which could cause fever and jaundice, but it is not typically associated with shock and biliary colic. The patient's symptoms suggest a more severe acute complication, such as answer C. Acute pancreatitis often presents with severe abdominal pain, fever, tachycardia, and shock in patients with gallstones, especially after a biliary colic episode, making it the most likely diagnosis and the correct answer in the 2024 exam that was taken in the summer of 2024. All right, so let's go with a sample question, a facsimile as they call it in Italy. A 75-year-old woman with a known history of multiple gallstones for years, she presents to the ER in shock. She has, like the previous question, hypovolemia, tachycardia, sweating, fever, jaundice. This after an episode of a biliary colic that started 3 days earlier and was treated at home with antispasmodics. Laboratory tests show a serum lipase of 500 UL, normal values between 0 to 160. Total bilirubin of 7 mgdl, normal values being 0.1 to 1.2 mgdls, with significant leukocytosis and neutrophilia. The abdominal ultrasound reveals a distended gallbladder with multiple stones and dilation of the intrahepatic bile ducts. What is the most appropriate immediate management for this patient? Let's look at the answers. You can stop the video now. All right. Answer A. Emergency laparoscopic cholecystectomy. This procedure is indicated in cases of acute cholecystitis, but with signs of shock and possible complications like cholangitis or pancreatitis, immediate surgery can be dangerous without first managing the underlying complications, in this case shock. So the patient is in critical condition. What do? We have to stabilize the patient. We stabilize her and we have to address the underlying cause, and that is the priority before even considering any type of surgery. So answer A is not correct. Answer B, ERCP, endoscopic retrograde cholangiopancreatography. You do that with a possible sphincterectomy and stone removal from the common bile duct, ERCP, which, it is indicated with patients that have a suspected clinical picture of acute cholangitis, and also the whole common bile duct dilation that is associated with gallstones. So, given the elevated bilirubin and the bile duct dilation, it is likely that the patient does have cholangitis, which is secondary to bile duct obstruction. So yeah, ERCP allows for stone removal from the common bile duct and can reduce the infection, stabilizing the patient before considering later surgery. It's quick, then you bang on some antibiotics in the meantime, and I would say B could be likely, but let's still look at the other ones. Answer C, percutaneous removal of the gallbladder. This approach is less common, and it is generally reserved for high-risk patients who cannot tolerate surgery. However, it would not address the bile duct obstruction, which is the primary cause of the patient's clinical condition. So I would say no. D, broad-spectrum antibiotics and supportive therapy with clinical observation. All right, while antibiotics are necessary to treat the underlying infection, I fully agree, they alone, by themselves, will not resolve the bile duct obstruction, obviously. That's what's causing the cholangitis. So giving antibiotics and then just observing the patient, observation without any intervention to relieve the obstruction is useless. It just worsens the situation, so you have to act. So D is not correct. Last one, E. Treatment with somatostatin and percutaneous biliary drainage. Right, so percutaneous biliary drainage is an option for critically ill patients who cannot undergo ERCP or surgery. However, in an acute setting like this, ERCP with stone removal is preferable, as it provides just a more direct solution to the bile duct obstruction. So to recap, answer B is correct, ERCP. You pair that with also a possible sphincterectomy and also the stone removal from the common bile duct, and you got a winner. This approach directly treats the bile duct obstruction, which is likely causing the patient's shock and infection, and it also offers the possibility to stabilize the patient before any further surgical interventions.